Hello guys, welcome to my friend's channel Clinically Clear. He'll take
Good, good, good. Hello, guys. Welcome back to Clinically Clear. Today we'll be covering another important topic, that is polyp. Let's get started. So, first of all, we have the bilateral ethmoidal polyp. Now, bilateral ethmoidal polyp. See, this table that I put here is for differences compared to antrocoinal polyp. We'll come to that later. So first, let's look at just the bilateral ethmoidal polypi. See, bilateral ethmoidal polypi is also known as sinonasal polyposis. Also known as sinonasal polyposis. Generally, bilateral ethmoidal polypi is due to systemic conditions, not due to local conditions. Now, let's look at the causes. First, let's look at adults. In adults, the most common cause for bilateral ethmoidal polypi is allergy. Allergy meaning what will be there? Watery nasal discharge will be there. Sneezing will be there. Itching will be there. Family history of allergy will be there. Increased serum Ig titer will be there. So, this is allergy. Second, aspirin exacerbated respiratory disease or something known as Samter's triad. Basically, in this, you have three things. You have triad, no. So you have a non-allergic hypersensitivity reaction to aspirin. People who take aspirin, and you have asthma. Why asthma? Because aspirin inhibits what? Cyclooxygenase enzyme. So there is increased activity of lipooxygenase enzyme. So increased production of leukotrienes. Leukotrienes cause bronchospasm. So asthma. See, arachidonic acid goes into cyclooxygenase, lipooxygenase. Lipoxygenase will go to leukotrienes. Cyclooxygenase will produce prostaglandins. Aspirin inhibits cyclooxygenase. So prostaglandins are no longer produced. So what will happen? All the arachidonic acid will get diverted to leukotriene production. So that's why you'll have asthma. Then bilateral ethmoidal polypi. That's exactly why I've written it under etiology of bilateral ethmoidal polypi. Samter's triad or aspirin exacerbated respiratory disease. Then you have Churg-Strauss syndrome, also known as adult onset asthma. Here it is seen in 30 to 50-year-old patients. See, all this you ignore. Just remember that when you take a biopsy of the polyp in adult onset asthma or Churg-Strauss syndrome, you will see a lot of eosinophilic granulomas. That is another thing. Then you have something known as Young syndrome. Now, Young syndrome is a ciliary dyskinetic syndrome. The ciliary dyskinetic syndrome, where you'll have three things. You'll have polyps, bilateral ethmoidal polyp. You'll have bronchiectasis, and you'll have azoospermia leading to infertility. So this is Young syndrome, which is ciliary dyskinesia. So in adults, what is the causes for bilateral ethmoidal polypi? Most common is allergy. Then you have Samter's triad, aspirin exacerbated respiratory disease. You have Churg-Strauss syndrome, and you have Young syndrome. Aspirin exacerbated respiratory disease, Samter's triad is a non-allergic hypersensitivity reaction to aspirin. Along with that, you have asthma and polyps. Young syndrome, you have ciliary dyskinesia, so you have infertility, bronchiectasis, and polyps. Churg-Strauss syndrome is also known as adult onset asthma, comes at around 30 to 50 years of age. Lot of eosinophil in the polyps, eosinophilia. Coming to children, you have autosomal recessive disorder. You have two autosomal recessive disorders. Okay. Now the most common is cystic fibrosis. Now in cystic fibrosis, basically what happens? There is abnormal chloride channels. Now because of the abnormal chloride channels, there is thick viscous mucus secretion. This thick viscous mucus secretion not only leads to thick mucus in the nasal cavity, but also thick mucus in the intestine, so intestinal obstruction, thick mucus throughout the respiratory tract, so recurrent URTIs. Thick intestinal obstruction can lead to what? Pancreatitis. So stuff like that, because of all the thick mucus. Because of the thick viscous mucus, it is also known as mucoviscidosis. That is one more. Then you have primary ciliary dyskinesia. This primary ciliary dyskinesia, also known as Cartagenous syndrome, is very similar to Young syndrome. It is also a ciliary dyskinetic syndrome. Here also you have bronchiectasis. Here also you have polyps. But instead of infertility or azoospermia, you have dextrocardia. So this is about children. In children, you have two autosomal recessive disorders. You have cystic fibrosis, which is the most common, where you have thick viscous mucus secretion, and you have Cartagenous syndrome or primary ciliary dyskinesia. Next, coming to the pathogenesis. Basically, why is there edematous mucosa? Because of all these etiological factors. Why does the mucosa become edematous? Because of accumulation of extracellular fluid. When extracellular fluid accumulates in the mucosa, it becomes edematous. Simple logic. Now what is important is why does an edematous mucosa become polypoidal? See, this is a little bit of basic physics. According to Bernoulli's principle, what does it say? Whenever air flows at a very fast velocity, pressure is low. So what happens? Because of the etiological factors, as I mentioned above, those systemic conditions, there is chronic obstruction to the nasal cavity that causes narrowing of the nasal cavity. So this nasal cavity, which is normally, let's assume it to be a pipe, normally this thick, it becomes very, very narrow. And when it becomes narrow, what happens? The airflow is much faster. And when the airflow is much faster, the pressure is lesser. The pressure within the nasal cavity reduces. And then you have the sinuses opening into the nasal cavity. And the sinuses also contain edematous mucosa. So here the pressure is high, here the pressure is much lower. And as we know, always mass or air or whatever it is from high pressure to low pressure. So the edematous mucosa starts to get sucked out and leads to polypoidal changes. That is the pathogenesis of polypoidal changes based on Bernoulli's principle. Then coming to the symptoms. Now, symptoms of bilateral ethmoidal polypi is bilateral nasal obstruction. Now, other causes of bilateral nasal obstruction, 3 marks if I take. At the level of vestibule, it can be because of bilateral vestibulitis. Nares stenosis, what is it? Nostril get narrowed. Nares atresia, a membrane is formed over the nostril. This is vestibular level. And at the nasal cavity, bilateral obstruction is caused by what? S-shaped DNS, bilateral ethmoidal polypi, septal abscess, septal hematoma, then my bilateral ethmoidal polypi, chronic acute rhinosinusitis, all this. Then at the level of the nasopharynx, if I wanted to cause bilateral nasal obstruction, then what can it be? There can be a large antrochoanal polyp which causes unilateral nasal obstruction, then goes back and goes into the nasopharynx and then obstructs the choan on the other side, causing bilateral nasal obstruction at the level of the nasopharynx. So this, to understand this better, watch my antrochoanal polyp video. I think there I'll clarify it. And adenoid hypertrophy in the nasopharynx can block the choana from both sides. So at the level of nasopharynx, you have bilateral nasal obstruction. So this is a 3 marker. Bilateral nasal obstruction causes at each level, vestibular level, nasal cavity level, and at the level of nasopharynx, you have to remember 2, 3 each, enough. Then whenever there is nasal obstruction, there is recurrent rhinosinusitis. Why? Because there is no mucociliary clearance, so there's a lot of discharge. So there's recurrent episodes of rhinosinusitis. So there is headache, and there is rhinolalia clausa, hyponasal voice. See, when I obstruct this nasal cavity, my voice automatically becomes hyponasal. Why is that? Because airflow through that does not take place. So that is known as rhinolalia clausa. And hyposmia. Why? Reduced sense of smell. Why? Nasal obstruction. Air is not reaching the olfactory mucosa. So that is hyposmia. So these are the general symptoms: headache, rhinolalia clausa, hyposmia, recurrent episodes of rhinosinusitis, nasal discharge. These are all seen in every nasal obstruction case. Then coming to signs. Signs are when you do anterior rhinoscopy. As we know, bilateral ethmoidal polypi has more of anterior growth than posterior growth. So just anterior rhinoscopy is enough to visualize them. What can you see? You can see multiple small, grape-like, smooth, glistening, soft polypoidal masses, which is nothing but bilateral ethmoidal polypi. You can see it in both sides, multiple gray, soft, smooth, glistening polypoidal masses. If they are very large, they can sometimes protrude through the nostril. If it protrudes through the nostril, it suddenly turns pink. When it turns pink, it appears as if it is a malignancy, but it is actually not a malignancy. But remember, within the nasal cavity, it is always a pale gray glistening structure. That is how it appears on anterior rhinoscopy. Then next, coming to the diagnosis. Basically, on clinical examination, upon doing anterior rhinoscopy, I'll first see that there is a polyp. Then once a polyp is seen, I'll go for probe test. Now, probe test helps me differentiate that this polypoidal mass is not any turbinate hypertrophy or any other malignancy, not a foolproof test, but you can differentiate, because a polypoidal mass, polyp you can easily move it. It does not bleed. It is insensitive. It is soft. It is mobile. Whereas turbinate will be hard. Patient will sneeze when you put the probe on the turbinate. It can start bleeding. Even in malignancy, it can start bleeding. You cannot pass it all around the turbinate because the turbinate is attached, right? And the turbinate is, of course, immobile. Then, any polyp, once you think that it's a polyp, you have to do a CT scan to check for any bony extension or any erosions. Why? Because sometimes malignancies can hide underneath the polyp, especially age of 40 plus in elderly individuals. Then coming to the treatment of bilateral ethmoidal polypi. See, always we go for conservative treatment first. Now, we know that it is most commonly due to allergy. So, we want to suppress the allergic symptoms. So, we give antihistaminics, we give steroids. What do these do? These have anti-allergic effect. They reduce the allergy, they reduce the edema. So, because of all this, it can suppress the early polypoidal change. It can reduce the polyp size. Okay, fine. Now, it is not working, but still medical treatment is useful even if you are going for surgical treatment, because before the operation we give nasal decongestants to reduce the size of the polyp, and after the operation, surgical removal, post-op we give steroids to prevent the recurrence of polyp. So post-op steroids to prevent recurrence, pre-op topical nasal decongestant to reduce the size of the polyp. Fine. This is conservative treatment. Surgical treatment, as we know, for polyp, it is always gold standard is FES, functional endoscopic sinus surgery, where we use angled endoscope, 0 degree, 30 degree, 90 degree, 120 degree, 120 degree. So stuff like that. Angled endoscopes to enter the whichever sinus is required. Most of the times, ethmoidal sinus, and open the roof, improve the drainage, improve the ventilation, and also excise the polyp. And it is very, very important that along with the stalk of the polyp, you have to always excise the surrounding mucosa to avoid recurrence. So if this is the polyp and this is the surrounding mucosa, along with the polyp, you have to also excise the surrounding mucosa to prevent the recurrence of the polyp. That is it for bilateral ethmoidal polypi in detail. Now, just in brief, to help us differentiate it from antrochoanal polyp, we have this short table. Bilateral ethmoidal polypi more common in adults. Antrochoanal polyp more in children. Bilateral ethmoidal polypi grows anteriorly, whereas antrochoanal polyp grows more posteriorly. Here it originates from the mucosa of ethmoidal sinus or osteomeatal complex. Basically, that is the origin mucosa. Whereas in antrochoanal polyp, it originates from the maxillary sinus mucosa. Here the cause is mostly systemic. Most common is what? Allergic, multifactorial systemic cause. Then bilateral ethmoidal polypi has a much higher rate of recurrence. Whereas there in antrochoanal polyp, the cause is infectious and it has a lower rate of recurrence. Then bilateral ethmoidal polypi, you have multiple and it is bilateral. Antrochoanal polyp, just a single polyp and it is unilateral. Then bilateral ethmoidal polypi, you have grape-like masses, grape-like soft glistening masses, whereas antrochoanal polyp, you have a single trilobed polyp. Then here it causes bilateral nasal obstruction, whereas in antrochoanal polyp, initially it causes unilateral nasal obstruction, but if the antrochoanal polyp grows large enough, it can cause bilateral nasal obstruction. How I've explained in my antrochoanal polyp video. So that is it for bilateral ethmoidal polypi. If you have any doubts, please let me know. I hope you guys enjoyed the video. Thank you for watching.